For those of you who are new to Partners in Health Engage, we are a grassroots network of community volunteers and organizers mobilizing our communities to fight for health equity. Together, we generate new resources, foster public discourse, and advocate for policies that advance the right to health worldwide. This year, our network has committed to fundraising $100,000 and reaching 3,000 donors for the PIH Sierra Leone Maternal Center of Excellence. Part of this effort includes having thoughtful conversations about the structural inequities that contribute to poor maternal health outcomes in Sierra Leone. Our moderator today, John Green, will guide us through this conversation in the next hour. Green is a best-selling author, YouTube content creator, and passionate supporter and partner of PIH Sierra Leone. I started watching John Green's joint YouTube channel with his brother, Vlog Brothers, in 2013. Since then, Green has provided free education to millions of students through crash course videos, hosted his own podcasts, such as the Anthropocene Reviewed, raised millions of dollars each year through a community-driven charitable movement called Project for Awesome, and of course, his inspiring partnership with Partners in Health, dedicating his resources, time, energy, and audience to help address maternal mortality in Sierra Leone. I would now like to pass it over to John to help get us started.
I was muted. Amateur hour over here. I apologize, Shannon. Thank you for that lovely introduction and for giving our videos a seat at the table in your life in those critical years. I'm so happy to be here and to be able to talk with three people whom I admire very much, and we're really fortunate to be able to hear from these folks directly. This is such an honor for me, and I know that it is for all of y'all as well. So I get to introduce Dr. Bailor Barrie, who is the strategic advisor to Partners in Health Sierra Leone and also the co-founder of the Well Body Alliance and the Well Body Clinic, which is a critically important part of the healthcare system in Kono District in Sierra Leone. We also have with us Isata Dumbuya, who is a nurse midwife and the PIH Sierra Leone lead for maternal, neonatal, and child health. And so someone with deep, long expertise in the work that we're talking about today. And we are joined by PIH's Chief Medical Officer, Dr. Joia Mukherjee, who is best known in my house anyway, for her really wonderful book, An Introduction to Global Healthcare Delivery, which does not have the most riveting title, but is a really riveting read if you aren't familiar with it. Lots of PIHers have written lots of great books, but An Introduction to Global Health Delivery is the one that probably had the most immediate impact on me. So hello to all three of y'all. If you can start up your videos.
There's hey, Dr. John.
Mukherjee. Hi.
Hey, John.
Hi, Dr. Barrie.
John. Hey, John.
It's so nice to see y'all. I wanted to, I always feel like it's really important and helpful to start with historical context and to not imagine that we arrived at this moment out of nothing. I think it's really important to understand some of the factors that led to Sierra Leone's impoverishment and the challenges in the healthcare system there. So I wonder if that would be a good place to begin.
Absolutely.
Go for it, Bailor or Isata.
So I think Sierra Leone suffered through various situations or crises that led to the extreme poverty of its population. One, the long history of slavery, and Sierra Leone was the hub for slavery in West Africa. Slaves were brought there, and then the ship from Europe and America will come pick them from Sierra Leone. And after slavery was abolished, we also suffered a long history of the colonization, which we're colonized by the British, and we all know the British colony. They strive to, colonization happens in two levels. One, in countries where there are resources, and Sierra Leone is very rich in mineral resources like diamonds, gold, iron ore. they will focus in extraction, not development. And in countries where there is no minerals, they will focus on developing the people so that they can have taxes from them. So Sierra Leone suffered the history of like extraction and no development. And after colonization, the country was abandoned by the colonial masters, and then it was a struggle to pick up from that undeveloped state to a developed state. And during that process, it suffered a situation where most of the development happens in the capital city, Freetown, and the interior, the districts suffered a lot of the underdevelopment, and that led to a 10-year civil war that started in 1992 and ended in 2002. And then Ebola struck in 2014 again, that also devastated the country's healthcare system. But I mean, the history of the war what actually led me to start Well Body Alliance is the fact that I suffered through medical school. I had to hand copy textbook. I had to walk 40 miles back and forth to college while I was in medical school. And during that period, I was reflecting and thinking that Sierra Leone needs help. And I think even while most of my colleagues, sorry.
You're back.
Yeah. So while most of my colleagues left the country after graduation, I decided to stay back and at least serve the country for a while before leaving. And then I met one American doctor, Dr. John Kelly, who just came to Sierra Leone, and he has read about health and poverty a lot. He has read Paul Farmer's book, Tracy Kidder's book, Mountain Beyond Mountains, and he know about peer partners in health. So he came and talked about like health and poverty to me, and I was like, look, I live this life, I know what it means, I have this experience. And so we decided together to start an organization to support the amputated civilians of the Civil War, because Sierra Leone had the history. During the war, a lot of people were amputated, and a lot of them were not receiving any help. They just received this one-off support from like World Vision came, just dumped in prosthetists that are iron-based and left. Another NGO just came and do one-off support and left. So I told him, I said, if we want to help these people, we need to develop a sustainable organization. We need to start an organization that we can use that organization to raise money and support them. But I had no idea how difficult it is to raise money or whatever. I'm naive. But then we started Well Body actually to support the amputated civilians as clinicians. Before we started, we went around the country to see where the amputated civilians are. And then when I got to Kono, I will always tell the story. I was shocked by what I saw in Kono. Kono in those days was still the breadwinner of the country. But we admire people coming from Kono, because Kono, people that come from Kono, they have money. They have resources, they're wealthy. And so like when I went to Kono and stood at the main street of Kono, I said, wow, this is Kono. And it's about 4 years post-war Sierra Leone. And I was like, you can feel the existence of the war, like the aftermath of the war. Still burnt houses were still there. And like I told him immediately, I said, Dan, this is where we should start. And he was like, sure. I said, because this is the most difficult. And I have not even went to the healthcare, to the hospital. I have not even known the hospital, like how it is or whatever. Then we visited the hospital. There was nothing in the wards, like no beds. Patients were lying on the floors. And then we started Well Body in Kono, basically to serve the amputees. And then we started serving the general population and started seeing the difficulty and some of the impacts we were having. And we built Well Body Clinic, started serving and started the first thing that made me contact Joia and Paul is when we wanted to start our HIV/TB community health workers in 2008. I emailed Paul and he put me in contact with Joia. So PIH provided all the materials we used to train the CHWs. And in 2010, the government, like, because of the high maternal mortality in the rate, was the mortality rate in the world, they launched a free healthcare initiative, but was not well planned. They declared it in November 2009, and then launched it in April 2010. It's a bold initiative, but not well planned. So we still have people delivering at home. We have traditional birth attendants delivering at home, a lot of them in the community. And then the government passed a policy to stop all traditional birth attendants from operating. And that was like, whoa, this is gonna be bad, because like, women rely on this traditional birth attendants, and they really like should be part of the healthcare system, part of the healthcare workforce. So we launched a project called Maternal and Child Reduction Project, which is actually the predecessor of this Maternal Center of Excellence. We hired traditional birth attendants as community health workers to screen women in their community and bring them to the facilities. And we worked in three communities, and it was successful, but we don't have the resources to continue it. We launched it in 2012 and ended it in 2013 before PIH came to Sierra Leone. And I know I'll leave the history of PIH coming to Sierra Leone to Joia, but like but when we built Well Body and during that period of this project, we realized that there's a huge gap in delivery centers. Like, healthcare workers are not working. And one night I was working at the clinic late, I was walking home, I had people singing in the community. So I was like, what's going on? Then I heard they say, oh, don't go there, don't go there. I said, what happened? They said the woman is delivering. So I walked in, I sat down, and I saw a woman lying on the floor, and the women around were singing for her and like providing these nice songs and melodious songs. And the woman is sitting and massaging her abdomen or whatever. I said, oh, can I help? Like, then they said, yes. I went to the clinic, brought some sterile equipment. I came and helped them deliver the baby. The next morning I came, I asked the woman, I said, why didn't you go to the hospital? She told me something that really stuck with me. Like, do you know that those songs that they were singing, those songs, the kind comfort and peace that they give me is better than any painkiller I'm given in the hospital. And that made me think about, okay, what about if we can build a facility and hire these women to work in this facility and provide that, what is happening in the community, to the facility so that women can come. So we built the Maternal Center at Well Body, which I actually ran the New York Marathon to raise money for. And I'm not a runner, but like we built it and we hired traditional birth attendants to work there. And they are also providing those songs for women. And since we built it and opened it, Isata, correct me if I'm wrong, we reported no maternal death to this point, and we opened it in 2014. To now we reported no maternal death. And then the idea came to like, okay, why can't we transform this into a bigger project, which is the Maternal Center of Excellence? That means like, Well Body is a center of excellence. They're providing, but it's a clinic. So why don't we decide to build a Maternal Center of Excellence for the Kono district? And that's where the idea came about and discussion started. And now here we are. Thanks.
And I wonder if you can talk about how your personal history intersects with the recent history of Sierra Leone, and also how we got to now with maternal mortality and the huge disparities in maternal mortality that the MCOE is seeking to address and that your work seeks to address every day.
So I'm from a family. My mom had like 7 stillbirths before he had my brother, and it's because they have they opened then a Wesleyan Mission Hospital in in Kamakwe where we were born. And then they had a cesarean. We had all of us that she delivered. A cesarean section was done, and she was able to deliver my brother, my sister that died at the age of 12 months, at the age of 13 months from measles. And then she delivered me all through cesarean sections. And I grew in a very poor family, and it's difficult to access healthcare. And I wanted to be a doctor since I was 6 years old. I was playing doctor. I was like, as a kid, I was playing doctor, and I became a doctor through a scholarship that took me through medical school. And now I'm seeing what I'm looking at, like that history and like what is happening currently. My father also died from mental health disease, and now we're working in mental health. And it's all coming back together. Like, okay, my mother suffered through 7 stillbirths before she had my brother, maternal and child health and mental health. And all these issues, I went through them. That's why at first I didn't want to go into details. I said I lived through health and poverty, not like read about it or whatever. I lived through it, and now looking at this, what we're great. But I think I'll leave basically the details of this to Isata, because I think she'll be able to talk about this well.
Great. Yeah.
And yeah. So
yeah, Isata. So what is your kind of personal experience with it, and also with doing this work every day, and as it currently is in the pre-MCOE world?
Right. So I was born in Sierra Leone. I left when I was about 2 years old to go to the UK, but came back when I was around 8. So I did most of my last couple of years of primary school and all of my secondary school years in Sierra Leone. But this was mostly in Freetown. My father is from Kono district, and I was actually born in Yengama in Kono district. So when I was in Sierra Leone, we would come to Kono, but usually just for weekends. I never actually lived here, so didn't sort of integrate within Kono as a district itself, but I know about Sierra Leone. I know about Sierra Leoneans. When I went back to the UK, I stayed and studied. I did nursing and then midwifery and public health, and worked all my adult life in the UK in a system where everything is organized. Everything that you need to deliver good quality healthcare is there. Everything is structured, and you have chains and lines of command. But one of the things that I always remember, in midwifery school, you're in a class, even if you're sitting at the back of the class, and we're talking about statistics on maternal health, Sierra Leone was always, for as long as I could remember, this is back in 95, had the worst maternal mortality in the world. And people in the class would turn around, because I'm a proud Sierra Leonean, and look at you and say, what do you have to say about this? And I had nothing to say about why is it so bad. So we read about these things, and I remembered several years, I'm thinking year on year, with all the investments, with WHO has been saying this for years and have put in a lot of resources into improving maternal health care in Sierra Leone, but nothing seems to be changing. Either there's something wrong with these statistics, or is it really as bad as it is? So I started coming back and looking into what is the healthcare system really like in Sierra Leone, but this was mostly within Freetown. It was bad, but if you're just sort of coming for a week or two, there's not a lot that you can get in terms of actual in-depth reasons and causes, and be able to figure out what is going on here. So when I saw this job vacancy to work for PIH in Sierra Leone, the thing that attracted me the most was about the Maternal Center of Excellence, about this dream of building a place where we can be able to provide the same standards of healthcare as what I'm used to in England, as what I expect for every woman that comes into my care when I'm working in England. So I came, and I was shocked, because the reality was a lot worse than these figures that I've been reading in the book.
Mm.
So seeing women, young women that are young enough, I mean, some of them hadn't even really started living yet. They were in their teens. To come in, because they're pregnant, because they're gonna have a baby, because they did not come on time or did not have access to the right level of antenatal care. Nobody checked them. Nobody found out that their blood pressure was rising. Nobody found out that their baby was turned in the wrong position. Nobody found out that they were anemic and needed nutrition and all of these things that would have made their bodies be in their optimum state of health in order for them to deliver and have a safe and well delivery. This woman comes into our hospital, the Koidu Government Hospital where we work and support the Ministry of Health and Sanitation. And she proceeded over a period of hours to die from something that in any way, shape or form, had she been in the right setting and had access to the right services, this would not have happened.
Right.
This would not have happened. And when it does happen, because again, people were so used, this was the expectation, this was normal. I was shocked. I was crying every day. I was like, I can't do this. I had seen one person die, and one person that I knew of within all the hospitals that I'd worked in all my 20 plus years in the UK of working as a nurse and midwife. And now within a month or two, there's 4 in 1 month, 3 in another month. And this was not from, when you say a pregnant woman dies, you think, did she have was it an accident, as in a car accident? This is usually just about an acceptable reason. Or did she have an underlying condition? Did she have cancer? Did she have a cardiac condition? Was she sick? As in, not sick because of the baby, but here women are sick or become unwell every day as a result of being pregnant, as a result of trying to have a child, as a result of not having the resources and the people there to put the measures in place to prevent this from happening. And it hurts a lot. But people accept this. In the first few months, the nurses were always like, when I come in and you get the information, it's kind of, it wasn't blasé, but because I guess from the history that Bailor has given, there was a lot of death in this region, yes? There was a lot of death from the Civil War. There's a lot of death from Ebola. So people, in a way, had come to become a little bit desensitized, and women kept on dying from childbirth anyway. So it was seen as, well, if you go in to have a baby, if you come out, this is a celebration of your life. You are lucky and you made it. And if you don't, well, this is unfortunate, but it is what it is. And they move on very quickly whilst you're still standing there trying to process the information of how, what, and why. So it took a while to get used to, okay, these are the reasons why people are the way they are about maternity and maternal death and neonatal death, because in this case, you're talking not just about the mother, but also about the baby. And you also need to think about when the mother in labor or the pregnant woman dies, what about the family behind her? What about the children? What about the husband? What about her extended family, her parents? It has such a roller coaster event on the whole family unit. How do you start to plan and think, how can we change this? How can this, a lot of them should not have to happen. What are the reasons? What are the causes? Start looking into why? And some of the whys are really whys that can be addressed. A lot of health promotion and community engagement. Getting women to trust in the facility. Bailor explained a beautiful story about how women go to TBAs to give birth. Historically, the hospitals were all burnt down. The staff, a lot of them died, either in the war or in Ebola, a lot of them died. So when you come to the hospital, usually there's probably nobody there. And if they are there aren't the facilities for you to give birth safely. The environment wasn't clean. All of these things would add up to making women think and feel, I am probably better off giving birth at home, where I'm surrounded by a community, where I'm surrounded by people who are going to show me love and affection and care. I'm not going to go to a hospital where the staff are all going to be demotivated, disenchanted, and not interested in me. But over the years, and this is through PIH investments and other donors coming forward and just really trying to hammer down and trying to change the rhetoric of maternal health in Sierra Leone. Services started coming in. Our same unit since I came in from 2018 to now has grown and developed so much. Our nurses and midwives no longer say, when you come in, somebody has died, and just shrug and walk away. Oh, well, she died. No, women do still die, unfortunately, but not anymore because there was nothing anybody can do about it. They would die because we tried everything we could and we couldn't save her. So now the staff, they fight for the women with the training that we've given, with the mentorship. So train, but also mentor, be there by them, be there as a complement, encourage them, motivate them, show them that you, the staff, you're worth something. You have done this great today. You didn't think you could do this, but you have. And this is a great and wonderful thing. And what you have learned and what you are doing now is going to change the outcome for a mother, for her baby, for her partner, for her other children, for her family, for her community. It's going to change the whole landscape. So we fight at this one day at a time. Staff come to work on time, which was one of the first things that I'm like, these guys, they don't even show up half of the time. Now they're running to come into work because work is now a place that they enjoy being at. Work is now a place that they get fulfillment. Work is now a place that they achieve. Work is now a place that they are recognized for their achievements. And everybody needs a bit of that. So they come in for that. They come in to fight for the women that they're serving. They come in to make a difference. They come in to say that today in our unit, we don't want anybody dying here. When somebody dies now, they are upset. Every month, if we have a maternal death, we do a maternal death surveillance review meeting, during which we go over what was this woman's story, what was the journey, where did she start from, what went wrong on this journey, what can we now fix to ensure that another woman walking down this same path doesn't have the same outcome. So this involves making sure that we have the resources to provide the right kind of services to prevent these deaths. And these include all sorts of supplies and equipment, drugs, fluids, everything that you need to be able to make sure that women have the right access to the healthcare that would help them to get healthier and positive outcomes. We also make sure that we invest in the staff themselves and in their development and in their training. We make sure that we go out to the communities and talk to the women and talk to the supporting partners, talk to the Ministry of Health and Sanitation, work alongside them. Our unit has got staff from the Ministry of Health and Sanitation as well from Partners in Health. There is no difference between either of them. We go in there and we all work together as a unit to save a woman and baby's lives. This is the main priority, and everybody in there is dedicated towards doing that and putting everything they can into the whole system to make it work. We need to do more, yes, go out and engage women more, but also because of the work that we've done so far, women now trust us. Women come to our hospital. Oh boy, women come to our hospital. So we are at maximum capacity. People come to deliver, people come for checks, they come to access services, including non-maternal services, gynae services that were never available within the districts before. People come not just from within Kono districts, but from all other parts of Sierra Leone as well to access the care that we have, because we have the specialists and we have the equipment and we have the knowledge and the training to be able to offer these services for people. But sometimes they have to wait longer than they should have to because we do not have the space. We do not have the capacity. Women coming in to give birth, sometimes it's like, okay, let's hurry up. This morning, we were having to do one of our shuffle buffles, as we call it, like move this bed there, put that one there, put this woman here, put that one there, just so that we can accommodate more and more women as they're coming in. People are coming in and having cesarean sections, which before used to be, well, the baby is dead, but no. Our doctors are working to get them out, but what that also means is we need the space. We need the space to be able to continue to grow, and so that we don't have to keep women waiting, we don't have to turn them away. And we need this, and not just space for the maternity services, for neonatal services, our special care baby units. We have a new unit, a new space that we've just moved the babies to. The results already in 3 months are phenomenal. But yesterday I went in there and it was full. Yeah. They had 10 babies from inborn, they had outborn babies, it was full. And we're like, we're doing such a great job, but we're also at maximum capacity, which is why the Maternal Center of Excellence cannot come soon enough. This is a space and place where women in Sierra Leone would know for the first time that they are worthy of having the same level of care, the same treatment, the same access to equipment as anybody else in any part of the world. Any other developed part of the world, you can come to the center and be treated holistically, be treated well, be treated with respect, with love, with care, be treated better than the TBA could ever even begin to imagine to treat you. In the center, staff will get further training. We don't have, I mean, Bailor, listening to his story and everything that he had to go through to get his medical degree, there are people here that are still living and doing that. However many years later, this is not unusual. This happens. But this is a place that they can come to and get that training and get that information and knowledge because people like you out there made it happen. So we are really super excited. I mean, I cannot even express it enough about how much growth we've done, but how much bigger and brighter the future is going to be as we continue to make these changes. Step by step, year by year, we will bring those figures down. We will get to the stage whereby Wellbody, for over 5 years plus, has had no maternal deaths. This is one PHU in the districts. This can be a picture that can be replicated in every health facility within this district. And the Maternal Center of Excellence is going to work towards moving and providing that sort of level of care. Thank you.
That's great. That's super inspiring. When I was in Sierra Leone, you talked about the change in the decision to incision time when an emergency C-section is necessary, that when you arrived, and correct me if I'm wrong about any of these statistics, I have a terrible memory, but I also speak with great confidence, which is a bad mix. When you arrived, the decision to incision time, the time from when an emergency C-section was recognized as necessary and when it actually happened was something like 12 hours or over 12 hours, and in more well-resourced communities, it might be 45 minutes or 30 minutes, and that, but just with the current situation at KGH, y'all have still brought down the decision to incision time tremendously.
So you're right, John. I mean, a couple of years ago, the decision to incision waiting time was very long. I mean, it could be for emergency cases, in cases where we would say this is a category 1 cesarean case, whereby you're expecting that this baby should be out within the first 30 minutes or 45 minutes of this woman arriving. We were nowhere going near those targets, not at all. So more often than not, even after the operation, the baby would come out in a very poor condition or would have probably died. And the woman's health is also, very critical at this stage. But we have turned this around. I mean, this is one of the biggest achievements that we have been able to do as a unit, that those same times have been brought down. Now we have our category 1 emergency cesarean sections being done for 90% of the time within 45 minutes. And we're working to bring those down even further down to under 30 minutes. So the woman comes in and everybody, it's a team effort. It is not just down to one person. We recognize she needs to have a cesarean section. Automatically the team goes into overdrive. Somebody is calling, somebody is catheterizing her, somebody is getting blood, it's chaos for those 20 minutes or so, and we're usually bumping into each other. But the important thing is everybody recognizes she has to get to theater as quickly as possible. She must go to theater. We must get this baby out, and we must get this baby out in as good a condition as we can, and also get the mother out to recover from this safely and well. So we're moving, and we're constantly pushing to say that we've got to under an hour. We need to get to under 35 minutes. We need to get to under 30 minutes, so that we can also be saying that these are the targets, these are international targets set. We are capable of achieving it.
That's great. And this is kind of a question for both you and Joia, but when you talk about people having growing trust in the system, that's so important, and it's one of the things that separates the PIH models from a lot of health charities that sort of do vertical integrations. They come in like Bailor was talking about earlier. They come in and they give a bunch of prosthetic limbs, and then they leave, and that's their single intervention. PIH has a much more systemic focus, so much more kind of long-term solutions to long-term problems kind of focus. As that trust builds, I would think that you have to keep building the system as well, so that the trust will continue as utilization increases. Is that fair to say? And is that also an important driver of the MCOE? And Dr. Mukherjee, I'm also curious if that's something that you've seen elsewhere in work with PIH.
Thanks, John. And I was smiling so much when I was listening to Isata and Bailor. They're just heroes, in Sierra Leone and around the world for the work they're doing. So thank you both so much. I think that everywhere Partners in Health works, we see that if you do a good job, people come. And that seems so simple, it's field of dreams. If you build it, they will come. But unfortunately, often development is a blame game. And, I was thinking about your first question, John, about, what are the historic forces? And I think there's no historic force that's stronger than racism when we look at disparities in the United States and around the world. And we have socially constructed this fiction that African people, Black people in America, around the world are somehow less able, less deserving of care, and less smart. And so the fiction that happens a lot in development is that people get sick because they're not taking care of themselves. Wash your hands to avoid diarrhea, but there's no water, right? Women don't come forward because they don't understand that delivering in a facility is better. But none of those are true. People are smart and they make decisions based on the available knowledge they have. And when we arrived, certainly when Bailor arrived at Koidu General Hospital, nobody with a brain cell would have delivered their baby there. I mean, it was disgusting, not safe. And you would take your chances and stay home, not because you didn't understand that modern medicine is good, but in fact, because there was no modern medicine to be had in the hospital. And so stay where people love you and care for you and care if you live or die, even if it isn't state of the art. And so what we found is building systems that work with compassionate and kind people always come forward, and you don't have to deal with sort of any kind of unusual ideas. And I always say, look, everyone believes in alternative medicine. People say, oh, I'm praying for your child. That's alternative. Or people will go and use the GNC, General Nutrition Centers. That's alternative. That doesn't mean people then won't go forward for modern medical care if it is available and of high quality. And so trust is really related to delivering stuff and delivering stuff that works. And, we've seen it everywhere. And to see it in Sierra Leone, despite the long history of war in the region of Kono District and the hospital that, Bailor found in 2006 and that Partners in Health became engaged in 2014, it's really about the just phenomenal work of the staff and the whole team in making care work for people.
Yeah, I think that's so important, and I appreciate you calling attention to that. I think the challenge is always that as people do begin to trust the system because it is delivering for them, it has to continue to deliver for them. Mm-hmm. It has to continue to work. And that, at least for me, is part of why the MCOE is so Absolutely. Necessary and so immediately necessary, because we have to be able to say that.
And once we raise the standard of care, we have to continually train people, as Isata said. So
Yeah.
we have, now lots of different, materials that people haven't used before, or technologies. And so that ongoing training is part of raising the standard of care in the long haul for the country.
How do y'all feel like things are different from, say, 5 years ago, toward the end of the Ebola outbreak, and now in the healthcare system in Kono? And if you look 5 years further into the future, what further changes are you looking for and hoping for? That's for anybody.
Bailor, I mean, you have the most historical knowledge. I would just say that, I was on the boat, which you've taken, John,
Yep.
from the airport. And on the video screen, they were running these pictures, and it caught my eye because it looked familiar. And it was a government photo reel of Koidu General Hospital as the best hospital in the country. And, we don't feel like we're anywhere near finished, but it just shows you that the work we've done has been well recognized by the community, by the government, and is, creating so much interest that we have to expand to meet the needs of people. So in the first 5 years, I think we've done a lot to improve safety, but, quality of care. But Bailor, 5 years ago.
Yeah, I think before Ebola, the healthcare system in Sierra Leone, I don't know if that word is appropriate, is completely dysfunctional, and the government was trying, and they were trying to rebuild the healthcare system that was destroyed during the war and during the long history of colonialism and all those things. But since Partners in Health, and I've been working Kono like 8 to 10 years before Partners in Health came, and it was completely, we were trying our best. We were trying to work with the government and work with the hospital, and then develop our clinic. And in 5 years after Partners in Health arrived after the Ebola, we've seen like a drastic change in the perception of people to healthcare. And as Isata said, right now we're seeing a lot more patients at KGH, a lot more people at maternity, and all the. I mean, before Ebola, the patient that we were seeing at Well Body is about 150 patients maximum a day, and now we're seeing about 300 or 350 patients a day. But like fast forward, thinking about the next 5 years, what I personally want to see is that model being expanded to other PHUs, other healthcare facilities in Kono, which will basically eventually reduce the number of patients coming to Kono and Well Body, because if they have a facility that is fully operational and functional and providing high quality care just as Well Body, they will not have to pay they will not have to travel those number of hours to come to Well Body. Somebody will not come from Kumbayende to come to Well Body. John, you know Kumbayende, and you know how terrible the road is or whatever, but like
the road is bad. The clinic was also just way under, at least when I was there, it was way understaffed, undersupplied.
Yeah, terrible. Yeah.
So imagine if you develop that clinic to function and operate like Well Body, then patients around all our community will not have to travel that long distance and terrible roads to come to Koidu. So in the next 5 years, what I want to see is like the completion of the MCOE, and then the scaling up of the process into other healthcare facilities, and building a stronger referral system that could bring people that need critical care to Kono, to Koidu, then but those that need care that can be provided in the community can have access to the community, a clinic near them, fully operational, fully functional.
Great.
And just to add on to that, strengthening the care in the community is pivotal to overall maternal success. Having the Maternal Center of Excellence would go a long way to also strengthen that. Yes, it's in Koidu, but this will be a center where every community health setting would also benefit from, because their staff will come to the setting for training. They will come to learn about innovative and new ways of caring for their patients. They would be able to transfer the knowledge that they've learned from the Center of Excellence to go back to their health centers and be able to treat the women there with better and higher standards. Currently in Kono, when people get posted from Freetown or from other districts, because in Kono, there are not a lot of people, there are not a lot of clinical trained people. Most of the population here are interested in either mining or training. So the education level is low. Maternal Center of Excellence would also go a long way towards changing this. People would see this place and say, I need to go and learn something to make myself available to go and work here. So in terms of the whole infrastructure for the districts as a whole, it would make a difference. If you have a place like that right within your settings, you are going to want to do something in whichever way or departments to be a part of it. If you post somebody from another district to come to Kona now, you struggle to keep and retain them, for them to stay. They want to go back home and be with their family. They want to go back home and basically not be here. And we lose a lot of good staff this way. But when you have the Maternal Center of Excellence, this is a one-stop, a center where you can get everything that you need in terms of developing your career, developing yourself, growing, learning, teaching, and then impacting and changing patient care. So people will come to us. People will come here to seek better options, rather than us now having to do everything we can to try and attract and retain staff. It will be a case of, I need to go there because I need to go and improve myself. I need to go there to go and learn. This is where it would be for a lot of people within this eastern region of Sierra Leone. This is not something that is available in the country as a whole. So it's not just Kono that would be benefiting from this in 5 years' time. This will be a place where people come to gain knowledge, to grow, and to develop, and where maternal care would be the flagship for the whole nation.
Yeah, I think that's so important, that it's also a teaching hospital. It's also a way that the next generation of Sierra Leonean healthcare workers can get the training and expertise that they need. We got a couple questions and comments that I'm hoping to get to before we talk about how to close the funding gap. One for all of us, but that's directed at me, is what concrete interventions can we make in education and policy spaces in the United States to change the narrative about the history of injustice and open the door for transnational reparations in the future? I think a lot of it is about the way we teach history in the United States, especially the way we teach what we call American history. The Amistad Rebellion should be taught as an absolutely, for those who don't know, the Amistad Rebellion is a very important slave rebellion with Sierra Leonean enslaved people who won their freedom by force and then won their freedom again in the US court system, despite some pretty significant, significant racism is an understatement. But anyway, the story of the Amistad should be taught as a central fact of American history. It's one of the driving things that made slavery untenable, because the real story of how slavery ended is that enslaved people, by asserting their humanity in many different ways, made slavery untenable. I think if we taught American history that way, instead of seeing the United States as a bubble, seeing the United States as a force that was interacting with many other forces both before and after independence, we would have a better idea of the role that the US has played and is playing in the impoverishment of other communities. And if every student in America was learning that a generation ago, I don't think that having conversations about what you can construct as transnational reparations, or you can construct it in other ways. I think we would already be having those conversations more out in public. And so I think that's kind of my obligation as a internet educator. And I think it's where we need to push our education system. That's the only place where I have expertise, though.
The other thing I would just add to that, John, is that, I don't think people are well aware of how we are benefiting from the impoverishment of the ongoing impoverishment. So, I mean, one thing I talk about, and I think everyone should dissect, every one of us with this computing device that is more power than put men on the moon, we are indebted to Congo, because coltan that goes into that cell phone battery is only mined in the Congo. And so we are benefiting from the war, ongoing war, political instability, lack of tax structure in the Congo, child labor, slave labor. And so if we don't recognize that our privilege is directly connected every day, every minute we doom scroll on Twitter is directly connected to the impoverishment and suffering, then we need to do something about it. And I just feel like when I study things like the Haitian Revolution, which also ought to be taught in schools, because, Thomas Jefferson, the great thinker we know was a slave owner and an abuser of young women, also was the first president to embargo Haiti. And when we study the Haitian Revolution, we see that there was a lot of transnational solidarity around sugar. And women particularly saying, we're not going to put sugar in our tea anymore because we understand that our sugar is connected to the enslavement of Africans in Haiti. And so I think there are ways we can look at our current impoverishing practices and try to think about what that means.
Yeah, I think the way that we consume, all of us, the way that we consume, the corporations design it to try to make it so that we don't have to think hard about what we're consuming when we're consuming it. Because if we did, we would be making ourselves proximal to suffering that we would not bear. And they can't have us be proximal to that suffering because we would work harder to try to alleviate it, which would leave fewer of our resources for purchasing Diet Dr. Pepper, So I think that's something I have found that very helpful to grapple with every day. And it also means that whenever people ask, like, what are you doing for this, or what are you doing about this, the answer can always be not enough. And that can make you, as long as the answer is not enough, you know that you have to think about how you can do more. There's a medical question, so I'm going to stay the heck out of this one. With more than 50% of, this is from Keegan, with more than 50% of deliveries taking place at home without a trained clinician, how many women experience prolonged or obstructed labor, and how often do these women experience VVF as a consequence? And how do you treat VVF? Thank you so much.
I think this question is basically for Isata.
So quite a lot of women, unfortunately, still do have their babies at home in Sierra Leone, even in Kono district. What can be done about that? Again, it's a lot of community engagements. It's a lot of talking, because these are the cases that come in with the worst outcomes. So they're home and either taking prescribed drugs, illegally prescribed drugs that would end up with a ruptured uterus, or taking traditional medicines, same results. What can be done about this? We have to sort of work more and more with the government, with the local stakeholders, with the TBAs themselves, because the TBAs are a valuable and recognized source. Women will go to them because they trust them, they know them, they get this sort of personalized care that perhaps they still don't get from the hospital. The hospital is seen as a clinical place. Some of these women have never been to a hospital setting before. So coming there for the first time to have a baby can be threatening for some people. So it's about trying to cross that divide to say you can still get good quality healthcare in the community settings, possibly with a TBA there, but not doing your delivery and not getting into practices that are going to end up you having a ruptured uterus or having VVF. What we do for that is currently our OBGYNs are able to repair, and then we carry on educating the women and persuade them to say, with your next pregnancy, can you please come straight away to the hospital? So right from your antenatal care, we can start planning how you're going to deliver the next baby so you have a better and safer outcome. So it's a lot of engagement, a lot of health education and promotion that would help to prevent these things from happening.
Yes, so in addition to that, it's like what Joia said, providing the alternative. So it's like building the facility structures, making sure that they can provide the care that the woman expects. And because like, even if we talk to them, they still rely on the traditional birth attendants. There's a huge cultural reliance on them, and like, but engaging them to bring women in the facilities. But then when they come to the facility, which is the receiving end, they should receive the care that they actually needed. So it's a two-way highway where you need the community to accept and believe in that, but then at the facility also providing that high quality. And I think that's why the MCOE is critical, because it will provide training for not only people in the at Koidu, but other facilities to be able to provide that dignified and high quality care in the facilities.
That's a nice transition. Thank you, to talking about fundraising. I wish that we had all day to talk. I would hang out with y'all all day, every day if I could. But I do, before we end here, I do want to talk about raising money. We still have a gap. It's not a huge gap, but we do have a fundraising gap for the Maternal Center of Excellence. And so if y'all have any tips for us, or any thoughts for us about how we can work together to help close that gap, we'd love to hear them. Joia, you want to start?
How to close the gap. You know, this is what I lose sleep over, obviously, for the last 20 years, is getting people to care. I guess my dream of closing the gap is to make maternal mortality a women's rights issue. You know, I was so privileged to grow up as an activist and a physician in the HIV movement, and what I saw was these remarkable people living with HIV from the global north, many of still my friends, who once they got their treatment, they stood up for their brothers and sisters in the global south. And they said, you know, it's not enough that I'm okay. I want this mother in Soweto to be okay, or this sex worker in Thailand. And so I think we could make that statement. I mean, I had, as we say in medicine, all the rides when I had my kid. I had an emergency C-section, 5-unit blood loss, chorioamnionitis. My kid went to the NICU. I had a septic pelvic thrombophlebitis, for God's sake, hard even to say. And nobody ever assumed I would die. Nobody ever assumed I would die. Like, you know, I mean, I was in the hospital for 2 weeks, which is practically like, I mean, in the US, they kick you out after 24 hours. So I just feel like I'd love to see women, you know, I think we've taken on sort of abortion rights, and to some extent in this way, and reproductive rights. But the real thing that's killing women is, you know, is obstructed labor, is lack of blood, is not having a surgeon. And so I just would love to see women just stand up for this. I mean, I was at a conference once of women in medicine, and you know, and someone said, well, you would never have that kind of solidarity that you had with AIDS for other diseases, because, you know, rich people have AIDS and poor people have AIDS. And I said, well, you know, rich people have children and poor people have children. And how many of you in this room had a C-section? And Isata can tell you that the majority of C-sections we do still are to save the lives of the mom. Often the baby is already dead. Like in the US, we're doing it generally because the baby is in distress. But in Sierra Leone, it's because the mom is going to die. And so to me, that is my dream, is like, how do we get women to be, not distracted by small things and really look at the big thing of saving women's lives, takes the privilege that I have, that Isata had and gave up to go to Sierra Leone. And that Bailor's wife had, delivering in the US once, right? Once? Twice. So I think that's one of the ways, like, women are more and more in charge of philanthropic dollars, have, power of the checkbook, which we didn't used to have, although Donald Trump said he was going to put our husbands back to work.
I heard that, yeah.
Was so excited because I
My
thought
wife was so excited. She was like, finally,
husband.
he's going to get out of the house.
Yeah, I actually thought he'd find me a husband and then put the husband back to work.
Yeah, it's one of the rules. No,
Yeah.
but I think that's a wonderful way. I think that's such a good way of articulating it. And I think that's something that we can all go and take back to our communities. And so thank you for that. And thank you to everybody who has joined us today. What PIH Engage does is so wonderful. And we are so grateful for your $100,000 commitment to the MCOE. And I personally can't wait to go and see all of the wonderful things that y'all do with your life as I enter into my retirement and old age. But it's such a pleasure to be with all of you. I'm so grateful to all three of you for taking this time, but also for being patient with Sarah and me as we have learned about Sierra Leone and about the extraordinary work that you're doing. So we are really grateful and look forward to continuing the conversation.
Thank you.
Thank you, John. Thanks, Isata, Bailor. I miss you guys. Thanks, everyone.
Hope to see you all in person soon. Take care.
Bye.
Bye.